Welcome to The Doctor Will Hear You Now, a podcast featuring our physicians and other healthcare providers telling their stories, sharing glimpses into their daily work and mission, and showing what it means to practice medicine just a little bit differently. Healing you means hearing you, so let's talk. I'm Ben.
And I'm Lexi, and today we're welcoming neurologist and neuro-oncologist Dr. Ruth Fredricks and Amber Herron from St. Dominic's Hospital's Comprehensive Stroke Center to talk about stroke prevention and treatment. Dr. Fredricks is the co-medical director, and Amber is the program manager for the hospital's Comprehensive Stroke Center. So, welcome, Dr. Fredricks. Welcome, Amber. Thank you so much for being with us today. Can you start by telling us just a little bit about yourself and the work that you do at St. Dominic's?
Okay, I'm Ruth Fredericks. I'm a neurologist and a neuro-oncologist. My career has evolved. I trained at Duke and Wake Forest and then came back to Mississippi and worked my way into a private practice situation at St. Dominic's. I was at university initially for quite a number of years. We developed a comprehensive stroke center here over 3 or 4 years. We were initially a primary stroke center, then became a comprehensive stroke center. And I became more and more interested in stroke, as did the rest of my neurology colleagues who are an integral part of this, comprehensive stroke center. And basically, most of my practice is now devoted to a combination of neuro-oncology, MS, and stroke. Those are the main things we do. Our stroke center has grown every year by leaps and bounds. We do quite a bit of intervention. Mississippi is in the heart of the stroke belt, so we're quite busy.
I'm Amber, I'm the stroke program manager, like Lexi said, and my background, I am an occupational therapist by trade. I started working here at the hospital at St. Dominic in Jackson almost 12 years ago. I transitioned from an acute care therapist that would treat mostly stroke patients in the ICU and the floors of the hospital. I transitioned from that role in June 2022 to the stroke program manager. And now I try to impact stroke patients from a different level, overseeing the facilitation of best practices in stroke care.
That's great. Amber, could you give us an overview of what a typical day looks like in your life at St. Dominic's?
My day can vary. I try to attend some of our stroke alerts. A stroke alert, it means for us is we have an app we use called Pulsera, and it helps to streamline the care for the stroke patient, starting with emergency medicine or starting with the ambulance. We will get the alert that someone is suspected to be having a stroke from that app. We're alerted at that time, and we know to get things in order to provide care for that patient at the time that they enter our emergency department. I'll go and attend some of those, oversee things, make sure the processes are going according to plan so that we can provide the best and most timely care for our patients, because time is brain. The rest of my day is spent following up on stroke patients, making sure we're adhering to all the best practices, but best practices from the Joint Commission, the American Heart Association, American Stroke Association, those guidelines they provide for us.
And Dr. Fredericks as well, what's a typical day look like for you?
My day starts around 8:30 or 8:15. We come in, review the stroke patients that have come in. I spend my mornings until around 12 or 12:30 in the hospital. We have one floor completely dedicated to acute strokes. We have a neuro ICU and then an overflow ICU. So we have around 16 beds dedicated to stroke. We also have an overflow floor. I do the acute stroke rounds with a nurse practitioner, physical therapist or occupational therapist, a pharmacist, the hospitalist, and sometimes their nurse practitioner are all there, along with 2 days a week, the case managers round with us. The whole idea is to try to maximize the stroke therapy, both pharmacologically, blood pressure monitoring, that kind of thing, as well as start planning the discharge from the time the patient gets to the floor. The patients are transferred to that floor from the ICU, say if they had an intervention or if they were, sicker, they'll go to the ICU and then eventually they come to our floor. We have some that end up staying longer term but are more stable, just waiting for discharge. They go to an overflow floor. But my day starts with rounds on that floor, which is usually around 2, sometimes a little over 2 hours. Then we kind of tidy up things, and I go to the ICU and see some of the other patients that are mine. I start my clinic days in the afternoon. If it's a call day, obviously we can get up to 8 stroke alerts in an 8-hour period. Sometimes we get more than that. The day is much busier and definitely not manageable sometimes, but we do the best we can anyway. That's kind of my typical day.
Sounds like no day is the same, which I'm sure adds to the excitement, keeps it interesting. I want to talk a little bit about prevention. And when we first started our conversation about primary stroke centers and then comprehensive, can you tell me a little bit about the difference between those two and why is that important to know?
Primary stroke centers are stroke centers that offer full stroke care. They usually do TPA. They have neurologists, neurosurgeons. They are readily available to take care of an acute stroke. Basically, the difference between a comprehensive and a primary stroke center is that a comprehensive stroke center provides other services like interventional radiology, where the patients are brought in. There's a 24-hour neuroradiologist on call. There's a team that's called in any time of day. And there's a backup team in case we have 2 at one time who can go in and actually pull out the clot, drip TPA into a clot, take care of an aneurysm, that kind of thing. Kind of the step above what a primary stroke center does. In Mississippi, we have several different designations. There's a drip and ship type stroke center where they can take care of the patient in the ER. They have the ability to give TPA. They just don't have neurologists. So they work with the neurologists at the place that they're going to ship the patient to, and they can give TPA. And sometimes they can keep them if it's a small stroke, but if it's a large stroke, they send them usually to a primary stroke center.
Thanks for walking through that. It's good to know when patients who need our stroke services can come to St. Dominic's, know they'll have that comprehensive care. Stroke is one of the leading causes of death in Louisiana and Mississippi. Like you said, we're in that stroke belt, unfortunately. So learning signs and symptoms and risk factors are important and can save lives. Can you talk and walk us through what those causes of a stroke are and what are symptoms and signs that we should look out for?
Sure. I'll take you through the causes and then Amber can run through the symptoms and signs. So as far as causes, uncontrolled hypertension is probably one of the biggest we see in our area. Uncontrolled diabetes adds to it. Atrial fibrillation or some abnormality with the heart, such as a cardiomyopathy, which is the heart's unable to pump with enough force. So there's blood that pools in it and it forms clots. It can't pump enough blood to get to the brain. Perfusion pressure in the brain is lower than it should be. There's a heart problem a lot of times. There's either that uncontrolled hypertension or atrial fibrillation. Smoking is also an independent cause. Hyperlipidemia or high cholesterol is also a cause. Those are kind of the 5 biggies. Those are kind of the big things. The main thing is having people take their blood pressure medicine. I give a lecture on it just about every morning. That and nicotine. We had a person that came in the other day with a 3-pack a day history, and there's just no way around it. Had a small vessel stroke, which is what you see from that. Amber, you want to talk about signs?
Yeah, I'll talk about some signs and symptoms. Our big key point here is be fast, and y'all may have heard of that before, but be fast are the signs and symptoms you want to look for. Kind of the acronym: balance changes, eyesight changes, face asymmetry, arm asymmetrical movements, speech trouble, and then your last one is time, because time is so important. From the onset of your symptoms, those be fast symptoms, you want to make sure you are really paying attention to what time it is, because you have about 4.5 hours if your stroke is called ischemic or there's some sort of blockage in your brain preventing the blood flow. If you have that type of stroke, you have the potential to get a clot buster medication if you arrive at the hospital within 4.5 hours of that onset of symptoms. And then if you have what's called a large vessel occlusion, you got about 24 hours where you could potentially be eligible for a clot retrieval to remove the obstruction from the artery in the brain. I always try to remember, be fast, because time is brain, and brain is life. It's your function. It's who you are. Absolutely do not want to lose any of that you don't have to.
We've covered a little bit about the difference between comprehensive stroke center and primary stroke center. Is there anything else that you would say that might set St. Dominic's apart within the region for what it provides as a comprehensive stroke center?
For St. Dominic, we can provide care at all times, 24/7, for complex stroke patients that are eligible for the clotbuster TPA or tenecteplase or clot retrieval interventions. We also have neurosurgical intervention that we offer around the clock. Those are what set us apart as a comprehensive stroke center. Those are the things that we're able to offer that have given us that designation from the Joint Commission. We also have a post-treatment intensive monitoring area, our neuro critical care unit, to care for patients after they receive interventions that's so necessary.
The types of treatments that a patient would expect to get when they come to St. Dominic's. I think Dr. Fredricks, you talked about TPA. Explain for us a little bit more about those treatments that they should expect.
Well, TPA obviously is given out in the field. The state of Mississippi has what's called their healthcare alliance, and we have different systems of care. People have trauma systems of care within their state. We have cardiac systems of care, STEMI care, and then we have the STEMI system network to make the stroke system of care. Our state is set up with EMS basically throughout the state using the same set of orders no matter where you are. They have the same set of orders that take the patient to the hospital, the hospitals that are in the system of care, which are almost all the hospitals in the state. We all use the same set of orders for evaluation. We use the same set of orders for TPA or tenecteplase, whichever one they're using. So everywhere in the state, if we get a patient shipped into us, they've gotten the same set of orders that they would have gotten somewhere else that we use here. It makes it a very uniform system of care. It's very easy for us to pick up where they left off when they ship us a patient. So it's a pretty interesting thing. We also have transfer orders. So if the patient shows up in, say, Brookhaven, Mississippi, and they're transferred up here after TPA, then we know that everybody gets the same thing, no matter where they're transferred in from. St. Dominic's picks up TPA from a lot of patients. We take those patients because some of those hospitals can't accommodate them in case they bleed. We also have a set of orders for patients who are going through what we call the intervention, which is the highest level of stroke care available. When the patient gets here, they're evaluated. They may have already had TPA, the clot buster drug, but they're evaluated. And if we find that they have a clot in one of their vessels and it looks like we need to retrieve it, then our team is already here because we knew they were coming because of Pulsera, which is the communication that EMS has with all the hospitals. So the team is here. They're ready. The patient's taken to the interventional suite. The doctor's there, and he does the procedure, which can take anywhere from 30 minutes to an hour and a half usually. We also have metrics throughout the state that say, we want the door to CT time to be 20 minutes or less. We want TPA to be in the arm running within 45 minutes. And through the Healthcare Alliance and the Health Department in Mississippi, we're able to monitor all the hospitals and make sure that everybody's meeting the metrics. So we want a system of stroke care throughout the state to be uniform because it makes it so much easier on a comprehensive stroke center like us because we know what we're getting from everywhere else. So if you're in small town Mississippi, you're going to get the same treatment as if you were in our ER, and they're going to be held to the same standards. So it makes our job easier, but we're part of that network, and we are the Comprehensive Stroke Center. We have several other centers in the state that are working towards comprehensive, but comprehensive is a higher level of care. We also have neurointerventionists that are intensivists who've gone and done special training, and they're geared towards taking care of neuro patients because they are different. There are a lot of parameters that are different for a brain patient than there are for a heart patient. So we have to make sure we meet those metrics with our patients.
What you just said about statewide kind of closing that gap of time, is there any kind of collaboration, like a multi-state scenario where someone in Louisiana might have closer access in Mississippi for a program like this?
There's not a Healthcare Alliance collaboration with each states or surrounding areas. They aren't held to the same metrics that ours are as far as quality standards. But we certainly take patients from Louisiana. I would say several times a month we get patients shipped in for intervention here because we're closer than their nearest comprehensive stroke center in Louisiana. So we work well with each other. The ER doctors, interestingly, because there's so few neurologists in the area, the ER doctors have taken up the flag, and basically they all speak the same language that we do. We all kind of became level as far as the language, the orders, and the efforts. And honestly, it's across state lines. We've worked really well with Alabama and Louisiana as far as shipping their patients if they need to.
It's good to hear there's a collaboration there and the opportunity to go to the best place where you can get the best care, even if you don't live in Mississippi. You mentioned lifestyle. choices can help prevent stroke or even the causes of strokes. But what about those who do have a healthier lifestyle? Is it still possible for them to have a stroke? Even for our younger adults, they may not even be thinking that a stroke is even a possibility for them. But is that something that you still see happen?
Yes, there's a separate workup even for young adults. With younger adults under 50, we worry definitely about holes in their heart or cardiac malformations. We worry about hypercoagulability. Could there be something genetic that makes them have thick blood? Most of them get an arteriogram because we worry about vasculitis. It's not common, but you see it. You worry about a different set of problems. Sometimes there's trauma. Sometimes they have arterial venous malformations or aneurysms. They may show up a little bit earlier. So it's a little bit of a different thing. And yes, you can get a stroke with a totally normal lifestyle. Amber, you can speak to this. You've taken care of a lot of these patients.
Oh, yeah. Oh, yeah. There's definitely a need to spread awareness of prevention and getting to access healthcare interventions ASAP. We've had so many younger strokes, whether it be aneurysmal bleeds or ischemic strokes with blockages from sort of the sequelae of what Dr. Fredricks just referred to. We see our fair share of younger people.
Is there a reason why younger people, where you're seeing it more? Is there any reasons why, or are there different types of strokes that are more serious than others?
I think we see it more in younger people just across the board because the drugs have added to it a lot. I've been doing this a long time, but I don't remember seeing as many people on a stroke service, as we do now with drugs involved. Drugs are a real problem. Also, I think the awareness, like Amber said, I think people are more aware. We see a lot of patients that come in that have complex migraine, but because they're aware of the BFAST symptoms, a complex migraine can mimic a stroke. And sometimes they even do get a white matter change on their MRI. There are things now that show up on our doorstep that maybe if people weren't aware, they would have stayed home. I'm glad they come in because some of them have strokes. So it's a good thing. If they're complex migraine, we treat and they go home. But I'm just saying, I think awareness has brought them in, which is the good thing. That's a positive thing for what we do.
Are there ways that you communicate with patients who are going through a tough time? Or are there ways that you connect with their families to help offer them some comfort, some solace in going through some of these uncertain things when they come to our stroke center?
I'll address my part and then Amber can address the therapy part. But I mean, multidisciplinary rounds, which is what we do with that group of people every morning. We go in the patient's rooms, we show the scans to the family. So they actually see the stroke on the scan, which can be overwhelming when it's a large stroke, but they understand why their loved one has a deficit at that point. Then we can talk to them about all the facets. The therapists are there, the pharmacy's there. They'll talk to them about the drugs. So we do a complete multidisciplinary approach on our rounds every morning with those acute stroke patients. I think that alleviates some of their worry. I've always said living in limbo is the worst part about healthcare is when a patient doesn't really know what's happening or where they're going with it. And so a lot of times if you can walk in there with all the disciplines, all the subspecialty disciplines with you, the therapist, everything, then it helps the family at least have all their questions answered at one time. And there's not a lot of wait and see and that kind of thing.
These multidisciplinary rounds, Dr. Fredricks is speaking of, they're a little bit unique in what I had done in the past with multidisciplinary rounds. On our stroke floor at St. Dominic's, we go around to each patient room with the different disciplines like PT and OT, pharmacy, hospital medicine. So you'll have the hospitalist doctor there. You'll have the neurologist like Dr. Fredricks there. Everyone goes around to the patient's room. So we're not just sitting around a table discussing the patient. The family's there, the patient's there. We're all there at one time meeting to discuss what is best for that patient in that period of time. It gives the family the opportunity to get clarity on the patient's condition, ask questions, just put everybody in line with common goals for the best care of our patients. It really makes a big impact, in my opinion, because you do get to establish a better rapport with them. You do get to comfort that patient with words from the actual neurologist or hospitalist or therapist, all speaking the same language to that patient. And that means so much to them whenever everyone is on the same page, talking to you at the same time. Everyone has a common goal and it's for their good. So that has really, in my opinion, helped greatly bridge
The
that
only other
gap.
thing I would add for different centers that are interested in this, we have so 25 or 26 on that floor, and we round on them. And the first time you see the patient, obviously, with the team, you spend more time because you have to show them the films and everything else. After that, though, it's 10 minutes in the room. We do the exam on the patient at that time. When we do the rounds, I examine them. The hospitalist examines the heart, the lungs. I do the neuro just to make sure there's been no change from the previous day. So really, you've gotten a lot of your communication and exam over with. If you're talking to people trying to set up stroke centers, whether they be primary or comprehensive, this is a really good way to round in the morning, because when you're done with that room, you're done pretty much. That family's satisfied. The patient's been looked at. You've gone over the labs. That patient's nurse will present the patient that morning, tell us what happened during the night, go over the vital signs. So you've done a comprehensive look at that patient. From a stroke standpoint and from a hospital medicine standpoint, it's a really good way because everything is there for you. It saves you a lot of time. You couldn't take care of that many patients in that short amount of time and cover that much territory. It's kind of a good way to take care of business.
I'm sure you're seeing a lot of really good feedback from those patients and their families about that experience and process. I'm wondering if you could walk us through, just to kind of explain it better, the different types of stroke that you see, which ones are more serious than others, and also some that you're more likely to see right now at St. Dominic's.
We see hemorrhagic strokes or ischemic strokes. Those are kind of the main ones. Hemorrhagic strokes obviously are usually caused by hypertension, and they're usually in the pons or the subcortical area, thalamus, that kind of area, and sometimes brainstem. Neurosurgery is involved in those, although they rarely take them to the OR because most of them don't need it. We follow them. Again, hospital medicine follows them. Intensivists follow them if they're in the ICU. And I would say that's probably about a third of our patients, maybe not quite a third all the time, between a fourth and a third are bleeds, mainly because we have the capability of taking care of them. So we get a lot of those shipped in. And then the rest of them are ischemic or dry strokes where they don't have blood. They can be large vessel where they're usually wedge-shaped strokes. They usually are fairly large. They're in the cortex. Most of the time they could be in the cerebellum. And then you have the small vessel strokes, which are generally, again, where the hypertensive strokes occur, which is pons, sometimes cerebellum, and subcortex, thalamus, basal ganglia, that kind of stroke.
The ischemic strokes, or the strokes that are caused by blockage to the tissue in the brain, those are by far the most common type of stroke. The bleed strokes or the hemorrhagic strokes are less common but more devastating. You're more likely to have a death from hemorrhagic stroke or a bleed than you are ischemic, but both can cause devastating impairment and disability.
Is there anything you can do on the front end to prevent any of that? Or really, is it just making sure you're always in tune with your body and noticing if anything changes?
Well, the lifestyle choices, like Dr. Fredricks was talking about, being healthy, knowing your numbers, making sure you're taking the medications prescribed by your primary care physician, those types of things for prevention. Keeping your weight at a good level, big risk factors like she talked about, of course, diabetes, high blood pressure, cholesterol or lipid issues, keeping those in check. Hopefully people are seeking primary care because that is your first line defense against it, making sure your numbers are all in a good range, having a good BMI, body mass index, having a good weight, not being overweight, that kind of thing. Other things can be genetic, the vascular malformations, the holes in the heart, patent foramen ovalis. Those are in a certain percentage of patients, and those are just genetic from birth. You'll have those and never know it. What that does is it allows for blood to settle and pool in the heart, and it can create a clot that can travel to your brain, and that's what a stroke is. I'm trying to think if I missed anything. Basically, you have the lifestyle factors and then the genetic ones. You can't modify the genetic ones. What you can do is know the signs and symptoms and get help fast. Call 911 so that you can get the earliest treatment ASAP.
Yeah, that's great to know. If you don't have any of the genetic things, just staying in touch with your primary care provider and doing the screenings that you need to do can help make the difference.
When you were mentioning 911, this is a little bit off your subject, but one of the campaigns we have in the state through the Healthcare Alliance is a campaign called Dial, Don't Drive. There are advertisements that we put on, public service advertisements throughout the state, because if you have a network of stroke centers like we do, then the EMS people are very well trained to do an assessment. They do an assessment, a stroke scale assessment when they pick up the patient, and they can tell pretty much that this is going to be a large stroke or a large vessel stroke versus a hypertensive associated small vessel stroke. They can go by the exam, and if the patient falls into the category that this looks like this could be a large vessel that we may need to pull out a clot, they will take them to a center that can get them to us or to another center if they pull out clots. And so it starts with EMS. I don't know how it is in Louisiana. I just know in Mississippi, it's set up so that if you dial 911, you're going to start getting immediate, well-seasoned stroke care from the minute they walk up to you. We've even had them flown to us from football fields. If it was easier to get them to a football field and they knew they had a large stroke or a large vessel stroke, the chopper picks them up at the football field. Many a night I would come in and they've been shipped in from a football field or from anywhere that a helicopter could land. They landed in a clinic parking lot not too long ago. If the EMS, who are very well educated, they do a great job. If they assess and they use a scale that they're trained to use, and this is anywhere in the state of Mississippi, if they use that scale and it looks like it's a large vessel stroke that possibly needs clot retrieval, they will get that patient to a helicopter to us. It's really a well-oiled machine.
Hey, piggybacking off of that, Lauren Pogue, who y'all will be speaking with, her helicopter landed in her front yard. So there you go.
Funny that you mentioned Lauren. I'd love to hear more about her story. I know that she's a success story because of the care she received with us. So can you tell us just a little bit about that neurosurgery procedure that she had and what really made the difference in saving her life?
Lauren came to us. Her story is so unique, and there are so many aspects of it that we could talk about for a long time. But I'm going to keep it short and say that her husband is a flight medic. He recognized, and she too recognized, that there was something wrong. Whenever her symptoms started, she had the thunderclap headache, worst headache of her life. Told her husband, I think I'm having an aneurysm rupture. He called and got the helicopter to land for air care in their yard and got her from Meridian to St. Dominic's, which is about a 2-hour drive, would you say, Dr. Fredricks? In that 40 minutes or so. She comes here having seizures from the aneurysm that was in her brain. She was only 35 at the time. She gets here. She gets her medical images performed. After looking at those, the interventional radiologist who would typically go in and coil an aneurysm like Lauren's finds that it would be too dangerous to do this. So they decide for our neurosurgeon, Dr. Kerr, to come in and take a look. He puts her on the schedule and goes in and decides to clip this aneurysm. Her vessels are just not cooperating from the nature of genetics, things like that. There ends up being a rupture. There's sacrifice of one of her carotid arteries, and she ended up having a life-saving procedure that also came out with some disabilities. When she came out of surgery, she had some issues such as she couldn't talk, she couldn't use the right side of her body, she could barely hold her head up, honestly. After that, we went to work really hard with maintaining good blood pressure control, keeping a very close watch in our ICU to make sure all of her numbers stayed good, that she wouldn't have any other complications. Things like making sure her vessels didn't spasm in her brain that can cause an ischemic stroke after the fact, which is common with the type of bleed she had, which was a subarachnoid hemorrhage. We went to work with keeping her safe there, and also with her physical, occupational, and speech therapy. She worked so very hard. She was a rock star. We had her doing intensive therapy here at the hospital. I'm telling you, the first time I saw her, she was in ICU. She could barely hold her head up. Even just sitting on the edge of the bed, she required complete, total assistance to hold herself there in a sitting position. But by the time she left, she was walking with a moderate amount of assistance. And as we followed her after that through the clinic and just her becoming a friend to us, just because of how close we've grown to her and her family. She's now walking without any assistive devices. She can drive. She takes care of her family. She has a little bit of speech deficit and some trouble with her left eye, being able to stay open and not having double vision.
But that's just an incredible story for sure, and an excellent recovery for Lauren as well. I was curious how, in cases like that, how you would describe life after surviving a stroke and what recovery would typically look like for a patient.
She's back with her family. And the one thing I can say about this is the surgery was very difficult. The blood vessels were kind of wrapped around the aneurysm. It was all matted together. So in order to save her, he had to sacrifice the carotid, which is always something. I think nowadays we know that the aneurysm's taken care of. You can run the blood pressure a little bit higher so that you can try to crossover perfusion. Her stroke deficit, obviously it's a stroke deficit when you take the carotid down. She was treated almost like a stroke with an occluded carotid too. We kept her blood pressure in a range where she could tolerate it. We didn't want any bleeding, but we also wanted to perfuse the other side that was no longer had a carotid. It all becomes more of a science even after the procedure's done. You have to work at it, and then you have to implement therapy immediately. You want the therapist in there working with her so that her programs stay intact in her brain for her motor function and speech, everything. Yeah, she was a miracle. I had no idea she would come back as far as she did. She was making a few sounds. I mean, she could say la la and me, and things like that the day she left to go to the rehab center, but that was it. She couldn't really walk. She could move her leg at about 3/5, just against gravity. But that was about it. I really did not expect her to come back as far as she did. But there are a lot of stories like Lauren. I mean, nowadays we know so much more than we did when I started treating stroke years ago. So many people went to nursing homes then, and now they don't. They go home because of these interventions. So the whole world of stroke has changed. I'm so blessed to live through the whole thing and see it because it's really been phenomenal.
I was curious about just the general recovery for a stroke patient today, what that looks like.
What you can see is now the people who get TPA early on, some people come in and they're presented to the ER and they're mute and they're hemiplegic. That's the typical left internal carotid stroke or left MCA stroke. Those are very common. Those people all went to nursing homes. So that's probably 15% of strokes have that, maybe 18%. And most of them went to nursing homes 10 years ago. Now with TPA, if you can dial, don't drive, and get to the ER quickly, most ERs in most states are equipped to give TPA, and every ER doctor is trained to do it. They can get TPA. That's their first chance. If it looks like they have a clot, then they can get to a comprehensive stroke center and we can pull the clot out. So many of those patients nowadays go home in 2 days. They walk out of here, and it's just phenomenal. You're still going to have your patients who have large bleeds or who have large strokes, and they're going to go to rehab. We do make an impact on those now by making their blood pressure stay higher, making sure they're hyperperfused, make sure their volumes are kept up, make sure they don't get aspiration pneumonia, make sure they don't get UTIs, and make sure they don't get bed sores. And so that's our job as doctors and nurses. Once we get them out into a rehab situation, there's more movement, there's more intervention. So they do better. So I think overall the recovery is better than it was 10 years ago. But there are those patients that go home and not to the nursing home. One of the things that was interesting, we looked at numbers several years ago about the percentage of our patients that were admitted and were discharged to home versus a nursing home or rehab center. The numbers have totally flipped over the last 10 years. Many more of them go home than go to a nursing home, whereas it used to be flipped. More of them went to a nursing home. So the numbers have have just about flipped over the last 10 years. And it's all been from acute stroke intervention and acute rehab intervention. It's a good time to be in this field.
Yeah, that's incredible. And I'm sure that being at home and recovering makes all the difference to those patients. Being with their loved ones, being comfortable in a known space is just a game changer. It's so awesome to hear that we're at the forefront of that and we're contributing to that work. So, on that same vein, the future of stroke, where do you think the future of stroke care is going? Is there part of it that excites you or that you think is really just going to be a game changer in caring for patients who experience stroke?
I think more and more we're trying to get things into the field. Neuroprotective agents to be able to give them IV the minute the patients are picked up by EMS so that we can try to protect the cells. We're now giving TPA in helicopters. If they're flying somebody from somewhere else and they meet the marks for TPA, they fly it in the helicopter from one place to another in Mississippi now. We're not really doing it in the rescue ambulances, but we're doing it in the air. And also just the intervention techniques. They're coming out with new catheters every single day to help us get smaller and smaller arteries opened up. We're trying to get more and more people engaged in stroke as far as the smaller hospitals, things like that. So there's a lot of things coming down the pipe. I really think a lot of it is now going to be anything we can do to make the time reduced between the time they pick up the patient and the patient starts treatment. There was a study done in Houston where they had a CT scanner, kind of a mobile CT scanner in an ambulance to try to get the CT scan before they ever even got to the hospital so they could start therapy right then if they could. I think everybody needs to learn to get better histories. EMS does a great job. You got to communicate with EMS when they get to the hospital because EMS is going to talk to a family member if there's anybody around that can tell them what the last known well time was, because that's what decides what you can do when they get to you. Things like that. It's just education. I think the biggest things coming down the pike are going to be things that are done on the scene, whether it be neuroprotective agents or CT scanners or whatever. I mean, STEMI uses an EKG, so they've got one up on us. We'll never be able to do that for the head because we have to have a CT scan to see if there's blood. But a lot of things like that, I think, are going to be implemented. And Amber, you can talk about therapy interventions. I'm not sure. What are y'all coming up with?
Yeah, I agree, Dr. Fredricks. You want to attend to that stroke ASAP. Once the signs and symptoms start, A, you have to recognize them, and B, you have to know to go into action ASAP. Because once occlusion of that blood vessel occurs and brain tissue starts dying, neurological tissue is very hard to recover. You've got to get those vessels back open ASAP. I would love a mobile CTA, a mobile CT, because those are what you have to look at to determine, can you get the clot buster drug? Is it a bleed stroke or is it an ischemic stroke? Or are you eligible for a clot retrieval? Can you get the intervention that goes in and takes that clot out of your head and opens those vessels back up? Those are what restores the blood flow and helps you not lose portions of your brain to a stroke. That's what I want to see. I want to see clot busters being able to be given in all ground and air ambulances. Each minute you take away, brain tissue's dying. The faster we can intervene on those, the better. And the educational piece, knowing the signs and symptoms is so huge. A lot of times there's fear of going to the hospital. Oh, I don't want to go to the hospital. They're going to do this and that to me. And I totally get that. But it is devastating on the other side of it when you've seen the effects that taking too long or what could have been if I had gotten here in time. You don't want to have to entertain that. Okay, we've gotten here. We've done all we could. Now what's next? As far as the patient's hospital course, it really is driven by speech, physical therapy, occupational therapy, just being able to help recover that brain, the neuroplasticity that's there, which helps you to be able to use other portions of your brain to help control some of the things that were lost. I know that sounds overwhelming, and it is, but lots of things with therapy have come into play. Intensive therapy, e-stim, stimulation to the muscles, portable e-stim machines, things like that. The biggest thing you can do is 100% absolutely being educated on the signs and symptoms and getting assessed by a healthcare professional ASAP.
Oh, good points. I wanted to shift focus a little bit back to your personal experience working at the Comprehensive Stroke Center. Amber, I can start with you on this. I'm curious what inspires you in your work every day to keep doing what you're doing.
Just the love of these patients, knowing I can help in some small way to impact these processes that can provide them the best quality of life for the rest of their life. I became really passionate about stroke. I know when I was in occupational therapy school, I had a desire to be able to impact and help people who've had strokes. I don't know that I can specifically pinpoint where that desire came from because I hadn't had a family member who'd had a stroke at that point. But I had seen the devastation it caused in my schoolwork and in my clinicals and things like that. I just knew I never want to be that way. You never want to have to depend on someone else. If you can care for yourself and speak for yourself, you want to be able to do that. Seeing people who've been devastated by strokes really prompted a passion to prevent that or help these people in any way that I could. That started with occupational therapy for me. And now as this stroke program manager position came available, I also have a grandmother who's had a stroke. And of course, I know tons of people who have had strokes now. And I don't know, I just have such a heart for it. God has just given me such a heart to want to help them and provide whatever I can, whatever is in my capability to make their life better.
That's wonderful to hear. Dr. Fredricks, the same question. What's inspiring you each day to continue to do what you do?
The patients. It's just rewarding. They give you a lot more than you give them. Basically, put your feet in their shoes and they're paralyzed and some of them are crying, some of them are upset. Eventually, when you make little inches of improvement, which is what they do initially with us at the hospital, they get so excited about it. And I do too. I mean, it's one of those God things. It touches you when you know that you're taking somebody over the hump to where they can feel better and feel better about themselves. And then some of them have to realize they may end up paralyzed in some limb for the rest of their lives, but they learn to accept it. And they really give you strength to see how they can be so strong and try so hard. It just makes you feel good about the fact that you've made some impact on their lives. And they certainly have made an impact on mine because they teach you to be thankful for what you have.
That's wonderful. It's great that patients have both of you to help them and be in their corner. What's one thing that we can all do to better care for ourselves mentally, physically, spiritually?
For me, mentally, spiritually, I'm going to say prayer and reading the Bible is absolutely a necessity for coping with these things. When you see devastating strokes, you have to cope with it too as a healthcare provider because it's very scary and it can be traumatizing for us too. When I started working here at St. Dominic's back in 2011, I really had to learn how to cope with it and how to process through it and learn my role here with the patients. I've gone to just support with my coworkers. We would have devotionals and Bible studies to see what the Lord's plan was for us and how to get through some of these tough times.
As far as I'm concerned, a couple of rules. One, we all learned from a really great professor when I was a med student that he used to say, first, do no harm. Do no harm to a patient. First, do no harm to yourself. Second, treat your body like a temple. And if you do that, you won't do like I do and eat the wrong things and not exercise enough, but treat your body like a temple. And then the best thing from medicine is to follow the golden rule. Put your feet in somebody else's shoes, walk in them, and then you'll always do the right thing for that patient. Do unto others as you would have them do unto you. Put your feet in their shoes, you're going to do that. And then you just never mess up.
That's great advice to follow.
We did want to hear from you if there was something that we might not have covered or something we missed that you want to make sure listeners are aware of and patients in Mississippi are aware of.
I think dial, don't drop. It's the best thing. I've said it about 4 times because I think that's one of our biggest problems in Mississippi. One of the metrics we look at is EMS turns in when they go pick people up, how many people arrive in private vehicles and how many people arrive via EMS. We've improved by small percentage points over the last 6 or 8 years. It makes such a difference to let EMS take charge and decide what you need to do.
Absolutely. Know those stroke signs and symptoms and dial don't drive. The faster you can get help, the better your outcome is going to be.
I think those
Thank
are
y'all
great.
for doing this. Thanks.
Of course. Thank you. I think you've shared some great key takeaways for us and for our listeners to just keep in mind.
Okay, guys. Thanks.
Well, thank you. Thank you both for joining us. Appreciate you coming on the show. Thank you, Amber.
Throughout our conversation, our neurologists and doctors have reiterated that minutes matter, especially when experiencing stroke-like symptoms. Don't marginalize or minimize the warning signs. Every minute you wait or ignore the symptoms severely impacts your ability to recover from or even survive a stroke.
That's right. And often the person suffering stroke-like symptoms may not notice the effects, but a loved one will. If you or a loved one experiences any stroke-like symptoms, seek medical attention immediately. Dr. Fredricks and Amber mentioned the acronym BFAST as a helpful way to know what to look out for. And we'll have this information available in the show notes for easy reference.
So what does BFAST stand for? B is for balance. Is the person having trouble walking or with coordination?
E is for eyes. Is the person seeing double or experiencing vision issues?
F is for face. Ask the person to try to smile. If the smile's crooked, with one side of the face drooping, it may be a stroke.
A is for arms. Get them to raise both arms in the air. If the arms are uneven and one can't be held up for long, it may be a stroke.
S is for speech. Ask them to repeat a simple phrase. If speech sounds odd or slurred, it may be a stroke.
And T is for time. Don't waste another second. Call 911 immediately.
Remember, dial, don't drive, which means to call an ambulance to get to the hospital. Patients who do have better outcomes than those who have someone drive them because evaluation and treatment can begin as soon as emergency medical personnel arrive, often in real-time coordination with the care team at the hospital. And minutes matter when it comes to stroke.
Thank you again for joining us, Dr. Fredricks, Amber, and listeners, thanks for tuning in. We'll have everything we discussed and other helpful resources linked in the show notes. And we'll be back soon with more episodes of The Doctor Will Hear You Now, a podcast from Franciscan Missionaries of Our Lady Health System.
If you have ideas for topics you'd like to hear on the show, email us at podcast@fmolhs.org. Thanks for listening.